I want them to queue up down here for my introduction.
Muchas gracias. Sois grande.
Oof, this is terrible. Okay, I just need to.
My mic is live.
Okay, come on in and get your lunch. Buenos dias, and welcome, everybody. This is a session that we're going to be doing sponsored by Gilead Sciences. My name is Lisa Sturman. I'm with the global medical team for Gilead. Until last year, actually, I was in practice in San Francisco for 25 years treating HIV and doing a lot of primary care for my people with HIV. And during this session, we're going to talk about how to age positively with HIV. And we have a wonderful panel that I want to introduce. We have hopefully 2 people virtually that are going to be joining us. 3 people virtually. Do we have them available yet? I'll introduce the people that are here in person. So we have the honor of having Mayor Antonio Muñez here with us. He has been a city councilor in Sevilla since 2011, and he's been the city's mayor since 2022. Aha, there we go. As well, we have Angelina Namiba, and she is the founder member of the 4M Network Project in the United Kingdom. And virtually, we have Dr. Annie Sharkashvili, and she is the special advisor and team lead to integrated systems and services for HIV and health in the joint UN program on HIV and AIDS in Geneva. We have Dr. Giovanni Giraldi, and he's the associate professor of infectious disease at the University of Modena and Reggio Emilia in Italy. We also have Kate Mersen, who is a national program manager for the program Realize. And we have Marlene Bras, who's here. She's the director of the HIV Programs and Advocacy Department for IAS and also recently the executive editor of the Journal of International AIDS Society as well. So we're going to start out today with the mayor, and the mayor is going to come and give us a quick presentation, and then I will continue with the rest of the program. Please join us. Thank you.
Good afternoon, ladies and gentlemen. It is an absolute pleasure to address you today. Again, I'm going to talk to you about what we are doing in my city. My city is a lively, dynamic, open, committed, and ambitious city. We are the capital of the region of Andalusia. We are the third largest metropolitan area of Spain, and we are one of the largest urban agglomerations in Southern Europe. We have grown on the foundations of a number of civilizations, of different ways of thinking, different lifestyles, and coexisting in continuous projection towards horizons and scenarios of progress. And this makes us being a very tolerant city. To this city, 500 years ago, the first expedition led by Ferdinand Magellan and Juan Sebastian Elcano, which were able to sail around the world for the first time. More recently, we have been the world capital of the Ibero-American exhibition in 1929, which we are celebrating the centenary very soon. And at the end of the century, the 20th century, in 1992, we hosted the Universal Exhibition in Seville. In between both exhibitions, we have been able to show the world our city, a capital city, which is faithful to our past, but moving forward in the present, setting out a strategy for the future. Seville is a heritage city as a result of our past. We have many monuments, such as the Cathedral, the Giralda, the Alcázar. Some of them are World Heritage Sites by UNESCO. We have writers such as Machado, Cernuda, or painters such as Murillo, Velázquez. But above all, we are a city today. We are a modern city, advanced and committed. That is why we have taken on board, with no complexes, the leadership that we must have, and we are facing the challenges of contributing to HIV eradication as well as other sexually transmitted infections. That is why Seville, being fully aware of our need to give a decisive and firm response to this public health program, was the first city in Spain to join the fast-track cities for AIDS-free world promoted by UNAIDS, meaning the fast-track strategy. We agreed this in a plenary meeting of our city council in 2015, and we formalized our adhesion by signing it in May 2016. That was and still is our political commitment. This strategy is a bold, urgent, supportive, and sustainable action with many opportunities for all cities. And we have wanted to design and implement inclusive public health social policies. This strategy puts people at the center, and this strategy promotes disease prevention and health promotion and protection at the very center. The creation of the Fast Track Committee and the subsequent design of the Fast Track Plan Seville for a city without HIV and AIDS 2018-2022, which was our guiding document, give substance and strategic direction to our work, and they are the cornerstones of our strategy's success. Within the fast-track framework, Seville has overcome the goals known as 90-90-90-0, so that today, almost 90% of people with HIV know their diagnosis in Seville. 98% of them are receiving medical care, and 93% of them have an undetectable viral load, understanding it as untransmissible, as you very well know. The last indicator is equally important, and the objective is to have zero discrimination and stigmatization for the whole HIV/AIDS population. In this sense, we are committed to achieving in the city of Seville the elimination of stigma and discrimination towards people with HIV/AIDS by favoring good quality of life of these citizens. That is why we took on board the Social Pact for Non-Discrimination and Equal Treatment, implementing some of the actions in our city, such as, for example, the approval in the plenary meeting of March 2019 of an agreement by which HIV infection could not be a cause for exclusion in access to public jobs in our municipality. Our municipal government has grown in the work we do with the Andalusian public administration and the local civil society to create synergies that help us achieve the objectives of our movement and to guarantee the services we believe in. It is up to us to put ourselves in the shoes of people with HIV, especially people living in vulnerable or marginalized situations. We must mobilize resources, eliminate stigmas and prejudices. We must transform our societies, working closely together to meet the challenge. And at the same time, we must protect future generations, our youth, through information, education. And now, our objectives are to go even beyond, to go 95-95-95-0, and we are very close. We have the political will and the commitment from all parties in the Fast Track Committee. Our city is proud to be part of this initiative and to have led this great opportunity to promote and make progress in the great challenges that we have committed to achieve in the next years, placing public health at the center of the city's political agenda. The success of the Fast Track in Seville strategy, which is an example for other national and international cities, is based on the strength of the actual committee, which is made up of public authorities, the University of Seville, as well as other organizations such as ADARA, Atenea Foundation, Triangule, and Doctors Without Borders. I would like to take this opportunity to thank the health officials of my city council for the hard work they do in this matter. From the local health service, we coordinate with other institutions and we arrive where organizations don't arrive. So we provide prophylactic and tests for HIV/AIDS early screening tests. On the other hand, in June 2020, the City Council of Seville supported the network of Spanish cities committed to accelerating the eliminations of hepatitis C in Spain, hence developing a strategy for early development of this disease in vulnerable populations in the city. And we carried out a micro-eradication program in collaboration with these stakeholders. We are firmly convinced that the best antidote against discrimination and at the same time the best prevention strategy against HIV is knowledge, meaning having accurate information with the necessary scientific backing, and that allows local citizens to make the best decisions for their health. Therefore, from the City Council of Seville, we have been for more than 30 years organizing health promotion workshops in the community and association framework, including workshops on sex education. I would like to mention specifically, because we were pioneers nationally in developing and implementing this for the program, the workshop Yo También Siento, I Also Feel, for people with intellectual disabilities, their families and carers. And this workshop has been widely accepted, and we have organized 43 workshops during the previous school year, 2020-21-22. In addition to this, since we joined the Paris agreements, we have carried out yearly campaigns coinciding with the 1st of December. This year, the awareness-raising campaign will be targeting the fight against stigma and discrimination for HIV people. Time has arrived to face a new challenge, an even more difficult challenge. We want to make Seville a city which is free of stigma for people with HIV. And to meet this challenge, there's nothing better than this Congress, this symposium, and unity of action of all municipalities, all cities, in this necessary and just and international fight. Thank you very much for your attention.
Thank you so much. Thank you, and thank you for being here. Yes, we really appreciate the mayor being here with us today. I think it's a wonderful example of the government and the city of Seville and Spain, really a shining example of how we all need to work together to reduce stigma and to create a place where everybody with HIV can be treated with respect. And I'm going to come along now and talk about a platform that we at Gilead have been supporting lately on how to succeed going past what we now know of as undetectable viral load. And in the past, we used to focus on just creating the ability of people with HIV to be undetectable. But at this point, we have other health issues that are becoming more important. And we need to think about the entire HIV care continuum, both from prevention all the way through cure, and not focus specifically on undetectability. So we're going to figure out how we can live positively with HIV and support, as all of the people who are supporting people with HIV, all the way from providers to government to social services, to age positively. I'm going to go through a few slides, and then each of my panelists is going to have a few minutes to discuss as well. So just a few housekeeping things. We do have an app if you have already downloaded it for the conference. Or if you have questions, and we encourage you to have questions during this session, to just jot them down on a piece of paper, and we'll also have somebody coming along if you don't have the app accessible. And then as we go through, so what do we want to achieve today, right? Well, we want to reinforce the importance of long-term success in HIV care and focus on the need to facilitate healthy aging for everybody living with HIV. We're going to outline some best practices, and we're going to hear from our esteemed panel members about policy recommendations and access that we can ensure that everybody gets the ability to live a long, healthy life with HIV, and to also understand that being undetectable is untransmittable. This is a very important message that we need to convey. And then how do we advocate for our governments and other organizations to put in place policies and facilitate other equitable care measures to help people living with HIV age gracefully? So we have, I did introduce our speakers, and here are some photos. We finally have everybody on Zoom, I believe, too. Are our Zoom members going to be zoomed in for the session? Okay. And I'm going to just go into my slides. So HIV management goals have shifted. As we mentioned, it's still incredibly important to remain undetectable. And what that means is that that medications for HIV need to be tolerable first and foremost, accessible to everyone, and affordable. And those are three things that are very important to helping everyone maintain undetectability. But we've gone beyond that now. And what we're really looking towards is how to start rapidly, how to treat simply with one co-formulated pill if possible, or a couple if not possible, and to reduce drug interactions, have long-term efficacy, and improve short and long-term safety profiles to improve quality of life. And this continuum that we all know about that has been focused on 2020, of course, COVID came in and kind of screwed all that up for all of us, but at least we have these aspirational spaces where we can think of trying to get every country to 90% of people knowing their status, 90% of people on medication, and 90% of people undetectable. And as we heard from Sevilla, they've done an incredible job with this. And some places have done great jobs, and others we need to focus more on how to get them closer to these goals. But the UNAIDS also have these aspirational 2025 goals with 95%, and then they've also added this quality of life, a fourth goal. So this is health-related quality of life for people living with HIV. So it's not just enough to become undetectable, you need to really be able to enjoy the now normal lifespan that you have if you have access to medications that are tolerable for you. And this is a very person-centered approach, right? So each person needs to be looked at as an individual because everybody has different and specific needs. So we need to look at their age, not just where they are now for people who've been living with HIV for many years, but how do we increase this quality of life for people who become diagnosed at a young age? We need to start looking into their future. They're going to have a normal lifespan. How do we support them from the beginning? We need their medical history, their lifestyle, recreational drug use or alcohol use. Also, mental health has become a really important consideration for all of us, not just physical health like cardiovascular and disease prevention for cancer, but mental health. And then we also have to really make sure that we know all of the medications, so we need healthcare coordination as we go along. And then going beyond this, I think it's very important that we, despite having all these challenges, that we look not just at viral suppression, but comprehensive health care and the burden of the multi-morbidity, the other things that people living with HIV may or may not experience in their life. And as we know, many people with HIV have risk factors for lots of other medical conditions. And we need to start being very proactive to prevent these, and also discuss with our patients what's important to them. Because from a healthcare perspective, we may think we know what's important, but we really need this to be a two-way street with communication to the people living with HIV for this to be successful. And as I mentioned before, Gilead has created this narrative. This was a narrative that Gilead helped support, but that was created by an international panel independently. And they came up with this co-created idea that long-term success for people living with HIV is achieved when the best possible health-related quality of life and well-being with sustained virologic suppression throughout equitable, barrier-free access to durable, well-tolerated treatments that are robust and simple. And this framework has a number of different pieces to it. I'm not going to read them all out to you. It's basically what we've talked about of optimizing quality of life and lifelong integration with patient and person-centered care. And freedom from stigma, this is really the important one that I think we can address today. And each of these factors went into this panel. So we want universal access to care. This is very important that we have universal, tolerable, and accessible care. ART regimens that are simple, stigma elimination, and integration of healthcare, not just between the healthcare system, but making sure that the person who's being centered on feels comfortable relating with that healthcare system. As we know, that can be a real barrier. So optimizing health-related quality of life, this is very important. So patient-related outcomes, making sure we really pay attention to what the patients and the people living with HIV need. We want to minimize their drug-drug interactions, and we want to connect them with their services. So we want them integrated and feeling safe and not having shame when they discuss their HIV status, both with their providers and with any ancillary services they may be connected to. And this is going to take a village. We all have to support this because the person with HIV needs to feel comfortable telling us everything that's going on for them in order for us to really support them. And then freedom from stigma, and this is really, I think, the biggest global barrier. We really need to create environments in which stigma is less and less of an issue. And this is something we need to really support at the government level and at the country level as best we can. And I'm going to then pass it over after this to Angelina, who is going to discuss from her perspective what she'd like to share with us today.
Thank you very much. So I just wanted to start off by saying that, when I was diagnosed with HIV nearly 30 years ago in my mid-20s, all I wanted and prayed for was to get to the age of 30. So for me to be here today talking about aging well with HIV is actually quite a treat. And so when I was reflecting about how to, share my experience of aging positively with HIV, I thought, so I've been diagnosed with HIV for nearly 30 years, but actually my aging with HIV has spanned over about 4 decades. So I thought I'd just pick the different decades, talk about a bit some of the issues I've faced and how I've kind of addressed the challenges in order to age positively. So my first decade is I was diagnosed in my 20s, and I had to age very quickly and make some very big decisions very quickly. The first decision was, how was I going to cope with my diagnosis? And so I could either be very bitter or I could make the most of life. I chose to make the most of my life. The second decision was, I'd finished university and I was offered a job in almost the same week I was diagnosed, and I had to decide whether to take the job or not. So I thought, you know what, since I'm going to be dying anyway, I might as well take the job and keep myself busy while I'm working, which for me turned out to be one of the best decisions I ever made. So fast forward to the next decade in my 30s, I had to make decisions about, and to age very quickly, around how to cope with my treatments, as well as how to share my status with significant others. And in terms of treatments, the experience I've had with treatments over the years as I've aged is almost like the kind of relationship that you have with a lover or a partner over the course of your life. So I've had about 4 relationships and 1 night stand, and I'll explain how. So the first relationship I've had with treatment was when I was pregnant way back in 1998. And this is like the relationship you have with your first love, whereby you really want this relationship to work, and you do anything to keep relationship going for a good outcome. So I did. I was a very good patient. I took my medication as prescribed, and I'm glad to say that I do have a daughter who was born. She's going to be 24 next month, born HIV-free. So that was really, really good for me, and she's now a singer-songwriter. And then the other issue I had to deal, the second relationship I had with treatment was a few years down the line, because in those days, we didn't start treatment straight away. So I started treatment later on, and the first regime that I took worked really well. Unfortunately, it gave me quite a lot of side effects, but I stayed with it, pretty much like those relationships that you have in your 20s or so, whereby you will stay in a relationship and take all sorts of things that happen, even though you're not happy, but you just want to be in a relationship. So I stayed with my treatment regimen. And after a while, it got too bad, and I came clean, and how I dealt with it, I told my doctor about it, and he said, well, we need to change your medication. But I was, reluctant to change it because it was working well, my viral load was fine. So then he said, okay, well, there's an opportunity to join a clinical trial. So that's how I decided to change, because I thought, if I join a clinical trial, it means I'm going to be monitored closely. If anything happens, it will be picked up. And at the end of the day, I'm going to end up with a better quality of treatment. So that's how I dealt with that part of aging. And the fourth relationship was when I was a long-term inpatient in hospital and had to take steroids, but then it would have interacted with some of my medication. And so they decided to change it while I was in the hospital so that, it could work well. So that was my one-night stand. And then the final relationship that I'm having is right now, after I came out of hospital. It's a one-a-day pill, which is working really well. So I'm hoping to grow old with this relationship. However, if a better relationship comes along, I might dump this one and move in with the new one. So that was my relationship with treatment. In terms of aging and dealing with stigma, I think the key thing that I had to deal with first is around sharing my status. And from earlier on, I felt that it's really important that we are visible, because a lot of the stigma that happens is from the perceptions that people have around us, people living with HIV. So I decided in my 30s, we're into that decade now, to be open about my status, but I knew, of course, there could be consequences. So how I decided to deal with it was I said, well, actually, HIV is a very tiny virus. It doesn't define who I am. And if anybody doesn't like the fact that me, because I live with HIV, then they can walk. Because I asked myself, Do they pay my bills? Do they pay my rent? Do they feed my child? No. So if they don't, then I don't need them in my life. But I have to say that I'm acutely aware of the fact that there are women in my position who are both economically, emotionally dependent on their partners. So for them, it's not a choice. They cannot be open about the status. But I will continue to do so because I have the support around me. So that was my third decade. My fourth decade is when I got comorbidity started happening, high blood pressure, but I dealt with it by taking the medication that was prescribed. Up forward to my fifth decade is whereby I started encountering frailty and the menopause. And in terms of how I dealt with it, what happened was I was a long-term inpatient, came out, I was doing really well, and then I had a very small fall, and I broke my tibia and my fibula. And it was a very small fall, and I wondered, well, you know, why did that happen? So of course they did the DEXA scan and all the other tests and found out that I had osteoporosis, so I had to deal with that. So I accepted that. And the final thing that I had to deal with was the menopause. But I was lucky, I think it started happening whilst I was in hospital. So if anything was going on, I didn't feel it so much because I had so many other things happening around me. But the way I've dealt with it and continue to deal with it is I've joined this project called Bearded and Flashed. It is a project that's been put together by 4 HIV charities in London, in NAS Project, Positively UK, Sophia Forum, and the Forum Network of Mental Mothers. It is a project that unapologetically looks at stigma and looks at ways of supporting women living with HIV or going through the menopause to age well with the menopause and release our creativeness in terms of writing about experiences of going through the menopause and things like letters to our lady parts. So that is what how I've dealt with that part of my aging. And last but not least, I'm just glad to say that as I enter my next decade, I am not just aging positively with HIV, I'm actually aging disgracefully. Thank you.
Absolutely. And please write your questions down if you have any questions as we're going along. At the end, we're going to have lots of time for question and answer. And I'm going to pass it to Annie. And Annie, I have control of slides that you might have. Do we have Annie on Zoom here?
Hello, Lisa, can you hear me?
I can hear you, yes, thank you.
Fantastic, thank you. And thanks in advance for advancing my slides.
Let's see if we can see these.
I can't see, but
I can't.
I assume that they are on the screen.
There we go. So let me make sure we're at the first one here. Yes, so here's your first slide. Can you see that on the screen?
Yes, now yes, thank you very much. So I'll try to squeeze my speech in the 7 minutes that I was asked to speak. And I will focus on aging for people living with HIV aged 50 and older. I'm sure other speakers will touch upon other contexts of aging. So next slide, please. And first of all, thank you very much for the invitation and the opportunity to speak today, especially to Dan Murphy and Lisa, to you as well, and all the other speakers. It's well known that the widespread use of ART has drastically improved the lifespan of people living with HIV that Lisa has alluded to. Aging presents a special set of medical and social issues that can be exacerbated by being HIV positive, including but not limited to increased risk of comorbidities or co-infections, need for optimized healthcare, addressing psychological and mental issues, and improved social and other support and protection. So next slide. So we at UNAIDS estimated that in 2021, 8.4 million people living with HIV were aged 50 plus, with Eastern and Southern Africa accounting for nearly 46% of this total population. Although the global HIV incidence has declined in recent years, incidence of new infections among this age group has fallen less dramatically, if you could see on the top left figure. And this fact is most significant for populations residing in Eastern and Southern Africa, where those aged 50 plus accounted for nearly 1/3 of new infections last year. You could see it on the right side up in the corner. This high incidence is accompanied by high mortality among older people living with HIV, as shown on the bottom left corner figure. Although global trends have fallen in previous years, AIDS-related mortality remains high among them, with the highest numbers in Eastern and Southern Africa. Death among those who have been living with HIV for more than 20 years account for nearly a third of both AIDS-related mortality and also death due to other causes. This excess mortality has been linked to unique challenges faced by this age group. And as a longitudinal study of mortality among people living with HIV in the UK found, only 58% of the deaths were from AIDS-defining illness, while other 19% were cancer, 19% cardiovascular disease, 18% in other infections, 12% liver disease, 6% substance misuse, 5% suicide, 5% accidents, and 17 other causes. In India and 5 other Southeastern Asian countries, 47% of death among adults and children with HIV were shown to be non-AIDS infections. These unique issues have been under-addressed in efforts to reach 95-95-95 goals that Lisa had mentioned. Please see figure on the right, and I'm sure this study would be referred to later on. This was across 13 African countries, and it was found that older people living with HIV had suboptimal HIV care and treatment outcomes, especially with regard to immunological and virological responses. While older people living with HIV achieved the second and third 90 fast-track targets, only 80% were aware of their status for HIV, emphasizing the need for targeted testing interventions to ensure access and uptake of HIV prevention as well. And Shannon Farley and other co-authors argue that older people living with HIV have specific unmet needs, which include depression, cognitive impairment, and frailty. Globally, nearly half of older adults with HIV are diagnosed late in the course of their disease when they have already advanced HIV disease. In Ukraine, older people living with HIV were found to be tested positive for HIV, more likely to have AIDS diagnosis or already a progressive AIDS disease. These conclusions echoes those drawn by a similar recent study in South Africa. A modeling study conducted in the US showed that the benefits of early diagnosis and ART treatment are most impactful for those aged 50 plus, and that all causes mortality was most greatly reduced for the age group when ART was initiated early. Next slide, please. Not on this slide, but I want to talk a little bit about multi-morbidity that Lisa also mentioned. In France, 62% of older people living with HIV had one or more comorbidities, and 70% were taking any additional medication in tandem with HIV treatment. In the PEPFAR programs, they already see 20% of people living with HIV being 50 plus, and it's clear that those have the highest proportion of comorbidities compared to younger age groups. The most common of those are hypertension, high cholesterol, cancer, cognitive impairment, and liver disease. And many of these conditions can be linked to certain long-term use of ARVs. The choice of regimen must be made with careful attention. So on this slide, for example, in the observational HIVHosted cohort study supported by PEPFAR in 4 sub-Saharan African countries, a high burden of NCDs was reported that varied by countries. Over a quarter of people living with HIV aged 50 plus had elevated blood pressure, and over 15 had dysglycemia. While this analysis did not focus on etiology, the risk of renal disease reported among people living with HIV that were older can be modified by changing ART regimens. Another unique comorbidity is mental health issues. Older people living with HIV experience mental decline more rapidly than older people without HIV. So there is a direct biological impact of HIV, higher prevalence of comorbidity and co-infections, social isolation and polypharmacy, and neurocognitive impairment among this older group translated into a lower retention in care and ART adherence in many countries. Another co-infection that I want to emphasize, which is TB, which is still a main killer of people living with HIV across the board. According to the University of Singapore study, to be published soon, older people living with HIV face the increased risk of developing TB or reactivation of TB because of age-associated immune dysfunction, the presence of other comorbidities such as diabetes, as well as malnutrition, chronic respiratory diseases, all more significant in high TB incidence settings. Additionally, poor mental health often has been associated with higher HIV and TB infection rates. And one more co-infection and comorbidity, which is HPV and cervical cancer. The highest incidence of cervical cancer is observed among women 45 and older due to the HPV infection cycle. So WHO recommends in its 2021 recommendations to screen not only 25 to 49 priority age group, but also those above 49 that have not been screened for cervical cancer, and obviously to ensure access to precancerous or cancer treatment. Several unique social issues contribute to excess mortality, one of them being the social assumption that older people are not sexually active or not likely to be at risk of other types of exposure that create barriers to accessing protective information, early HIV testing. And women especially are seen more like sexual and reproductive bodies rather than those that throughout their lives, including up to 49, need better overall health and well-being. Older people living with HIV also face stigma being HIV positive together with social discrimination and that of aging and a social devaluation. Next slide that I would like to present is an example of in Rwanda, in Kigali, because of the reported high incidence cases of HIV among aged 50 plus and comorbidities, UNAIDS together with the city partners and others have started improving the adherence of aging HIV infected clients project, which had improved both adherence and comorbid outcomes of older people living with HIV, such as home visits, early screening for common NCDs, assuring social support, etc. And the last slide I'd like to show is a set of various global strategies and policies, including the Global AIDS Strategy for 2021 to 26, that emphasize the need for focusing on people-centered and differentiated service delivery among them for aging populations and key populations. And there is a variety of WHO as well as other global policies and strategies around this people-centeredness, which are all very much aligned, including the Global Fund's new strategy, PEPFARs, etc. So thanks very much for your attention.
Thank you very much, Annie. That was wonderful. We're going to move next to Giovanni, who is also in the virtual space, and he's going to share some of his experiences. He was also on this panel that helped us to create our ideas of long-term success for people living with HIV. Do we have Giovanni available?
Hi, and thank you for inviting me in this very interesting meeting and panel. And so first of all, I would like to speak as a clinician. I lead a metabolic clinic in which in years have been used to take care about the needs of older people living with HIV. And of course, I realize that there are so many, and it's so difficult nowadays to speak about aging. And so we've heard Annie speaking about aging, referring to people living with HIV. aged 50. Of course, as a clinician, I can say that it's totally different thinking about being 50 or being 65 or being 85 as a quite considerable proportion of people nowadays lives with HIV, and you may think that in consideration to the increased life expectancy, nowadays there will be more and more people that will be living with HIV above the age of 50 than what will be below the age of 50. Already most of people living with HIV have been living with HIV longer than without HIV, but this will even increase being living above the age of 50. Given that, as a clinician, I want to say that the third 90, that is undetectability, is not the aim of my taking care of people. It's just the starting point, because the long-term success, the long-term treatment is in fact the healthy aging. And I like to call this well-being, just to say we are speaking about health and not disease. And as a clinician, we need to say strongly that healthy aging is feasible. You can get a healthy aging while being living with HIV. Of course, we need to give meaning to these words. To me, healthy aging means, in fact, sustain as much as possible functional ability, that is making my people give a value to life. And this can be achieved even if I will not be able to avoid comorbidities that are age-related. But even if I've got comorbidities, even if maybe I've got disability that is produced of aging, healthy aging means I can be able to give value to life. And so how to do it? Well, first of all, you need to address which are the needs of people living with HIV. And to do so, you need to listen. This is very, very important. We need to listen more and actually listen different places, because the needs in one place is different with another. Think that aging is complexity, and aging is really the result of something that is affecting my biology. WHO likes to call it intrinsic capacity, how it is interfering with the environment. And we know that the environment, the different health system, the different society, the different, let us say, social security system is so different from place to place. And so how can I listen? There's one scientific way to listen. This is to collect patient-reported outcomes. And if you want to speak about aging, you cannot avoid of speaking about patient-reported outcomes, because most of the needs that people may have, imagine, for instance, fall, imagine urinary incontinence, imagine all this. There's no lab test to get. Either you ask or you will never get them. Okay, and so the issue to me is that, are we ready to incorporate the patient-reported outcomes, including quality of life, in the way in which we manage health data? How can I use this information in order to drive my intervention? But the second point is not just for me as a clinician. How can I use the patient-reported outcomes in order to engage people living with HIV? Because most of the intervention is not just medical intervention, it's intervention that people living with HIV will have to get within their community. And so to me nowadays it's very important that structurally the way in which we build our clinic that are able to take care of all the people may change, thinking that well-being is the goal, and thinking that patient-reported outcomes should be part of the things that we collect in order to do something. And so collecting patient-reported outcome is per se an active intervention that will engage people and community. All this, why in HIV? Why is different when compared to any other chronic diseases? I mean, HIV is not the only chronic disease. Imagine diabetes, imagine the chronicity of cancer now. Imagine neurodegenerative disorders, Parkinson's disease. Why we are focusing so much on HIV? Because we know piece of evidence to say that aging with HIV is different. We know that the chronic inflammatory process, the inflammaging, that is something that has been proven specific in HIV. We know the biological mechanism behind that makes aging trajectory being different. We know that aging is more pronounced, what we call accentuated aging. We know that gets faster, what we call accelerated aging. But most of all, let me say, there's something different regarding how people believe, perceive. And so on one side, aging in HIV implies higher burden of comorbidities and its complexity with regard to multi-morbidity. This means higher burden of polypharmacy and its complexity in driving this, higher burden of geriatric syndrome, both physical but also relating to mental health, for instance, okay? But let me say, there's something even more. That is a different stigma associated with aging. This is called ageism, okay? It's not unique in HIV, but there's a unique interaction between the stigma of HIV and the ageism. This reflects to institutional stigma, this reflects to interpersonal stigma, but it also refers a lot with, let us say, self-stigma of all the people. And the net result of all these many stigma that interplay one another, okay, interact with one another, is that people getting older with HIV are definitely more lonely. And this is something that even more striking, even more painful in the context we are thinking. Lonely is a problem of all people, of all old people, but it's particularly true in communities where there's less possibility to being connected to family of origin, to offspring, to children, with a socio-economical problem. And so most of the time it will end up to the fact that people are displaced in home-based care and even more will get alone. And so this is something we need really to tackle a lot. And so I believe that a meeting like this will have important political message, because there will be an answer that is political, that is social, and it is clinical. Thank you for listening.
Thank you, Giovanni. I'm hearing a lot of themes around really listening to our people with HIV and also documenting with patient-reported outcomes in lots of our research and going forward to inform our policy. So, and then, of course, the mental health, loneliness, and stigma that we all are trying to combat as well. I'm going to move to Marlene next because I would like to have somebody from the panel in person, and I'm going to end with Kate, so if you don't mind.
Sure, thanks a lot, Lisa. So it's a pleasure to be here today and to have the opportunity to address these very important questions with you all. So I'm speaking today with two hats. One as the Director of the HIV Programs and Advocacy Department at the International AIDS Society, and the second as the Executive Editor of the Journal of the International AIDS Society. And I'm going to talk a little bit more about that today. At the end of September, the Journal of International AIDS Society launched a special issue on growing older with HIV in the Treat All era. So very timely and very topical for this conference. So this is an open access journal, so I really encourage you to check it out. When you will be by the pool later today, just grab a copy, go online, it's freely available, and you will see a lot of the topics that have been discussed already in the session included in this supplement. So these articles in this supplement look at questions along the spectrum of growing older while living with HIV. So it ranges from resilience and suicidal risk among young adults living with HIV to comorbidities, co-infection, cognition, and mental health among older people living with HIV, including unmet needs for optimizing care for older adults with HIV. So Annie did a very good job at summarizing some of UNAIDS data. And what I think we can all be happy with is that the good news is that the number of AIDS-related deaths of people living with HIV is decreasing, has been decreasing for the past 5 years quite dramatically. If we look at the numbers, in 2015 there were 1.2 million deaths, AIDS-related deaths, and in 2020 it was 680,000. At the same time, the number of people living with HIV aged 50 years and older increased from 5.4 million in 2015 to 8.1 million in 2020. So these data are really telling us that the HIV response and the health systems are doing a better job at increasing the lifespan of people living with HIV. What is missing a little bit is how well people living with HIV are doing while they're growing older. There are now more people living longer lives with HIV than ever before, and it is really crucial that we find the right response to make their life not only longer, but also healthier. Because despite advances made by health systems to improve the care of people living with HIV, as we've seen in the previous presentation, they still experience a higher burden of multi-morbidities, co-infections, and poorer health-related quality of life. So now I'm putting again my IS hat, because at the IS we are advocating for a person-centered, multidisciplinary, integrated, and long-term focused approach to care for people living with HIV. We, I think, all need collectively to recognize that quality health care for people living with HIV must integrate other health issues. And we need to be responsive to people's evolving needs and preferences and priorities, and those are also changing through the course of life. So these aspects are being covered in the GIS special issue that you're going to check out just after the meeting. But there are some important takeaways that I would like to maybe highlight now. The first one is that there's a new understanding of the fact of aging and what it means for the HIV response. We used to primarily think that aging with HIV was, we used to think of older people living with HIV. But actually, when we speak about those aging with HIV, we should not exclude young adults with perinatally acquired HIV in our way of thinking. We need to raise awareness for the unique challenges of those young adults with perinatally acquired HIV, especially related to mental health. I think we all remember that transitioning from, adolescent into adulthood is a tough one. It happened a long time ago for me, but it is hard. It coincides with increased self-awareness, establishing a new identity, and doing so within the setting of HIV-associated stigma, and with the embodied experience of living with a chronic health disease condition. As such, many of these young adults who are growing older with HIV are at increased risk of mental health comorbidities, such as depression, anxiety, and substance abuse. In one of the studies published in the supplement, the data was quite appalling. They had a quarter of the young adults with perinatally acquired HIV who reported ever attempting suicide. A quarter. That's terrible. So another thing that I would like to mention, and another important distinction that we highlight in the special issue and that my esteemed panelists have been discussing a little bit, is the necessity, the importance of reflecting on health span rather than just lifespan or mortality alone. It's concerning that people living with HIV continue to experience high rates of comorbidities and functional decline. In that regard, the special issue includes studies on renal disease, diabetes, neurocognitive impairment, mental health, and sarcopenia associated with increased adverse outcomes, including falls, functional decline, frailty, and mortality among people living with HIV in several countries. So while higher rates for comorbidities were found in some but not all studies, risk factors differed among those with and without HIV, and this highlights again the importance of considering each person as an individual and supporting their needs within their own contexts. Now, if we look a little bit forward at way of improving the situation and some of the solution, one of the papers in the supplement share lessons learned from PEPFAR programs, and they suggest that person-centered, differentiated service delivery models will be crucial to ensure high rates of adherence and viral suppression among the growing number of older people living with HIV, whilst addressing at the same time their other needs such as depression, cognitive impairment, and frailty. And they suggest in this paper that this could be achieved by task shifting of treatment delivery in order to extend this to the management of other well-established chronic comorbidities such as well-controlled diabetes or hypertension. Of course, this requires some efforts, and this may require in particular adapted educational materials, healthcare worker capacity building, and outreach designed specifically to treat this age group, meaning that we need to adapt the language and make sure that the framework we are working with are culturally adapted and validated to screen people living with HIV for age-associated and geriatric condition. So in closing, the studies in this supplement show how research can be used to guide policy changes, care and treatment of people living with HIV. Health systems need to evolve in response to available evidence. And if we think, as it is the topic of today's session, about aging positively with HIV, it doesn't mean living longer, but it means also living healthier lives, like happy, healthier lives, and that includes mental health and overall well-being. And I think that we all agree, listening to the other panelists, that this is something very key, and we need to change our approach to, from like a disease-focused point of view to a people-first approach. So thanks for your attention.
Thank you so much. I would encourage you all to look at the supplement. It's actually available, free access. Yes. And I read it last week just to check in. It's wonderfully written, and there's a number of different pieces involved in it. While you're thinking here, please do write down some questions. We're going to collect them or through the app, if you already have access to the app for the conference. We have one last speaker. Kate, thank you so much for being patient with us here. Kate Mersen, would you please go ahead and start?
Absolutely. Thank you so much, everyone, for having me. I just want to start by acknowledging that I'm currently situated on the traditional territories of the Erie, Neutral, Huron-Wendat, Haudenosaunee, and Mississaugas, and in the neighborhood of the Six Nations Reserve, otherwise known as Hamilton, Ontario, Canada. So thanks for welcoming me this morning here in Hamilton. So as Lisa mentioned at the outset of the panel discussion, I am the National Program Manager at Realize, which is a non-governmental organization in Canada dedicated to fostering optimal well-being for people living with HIV and other episodic disabilities. And in thinking about the question about what does it mean to age well with HIV, I was thinking about a study that we recently did where we did qualitative focus groups with people living with HIV over the age of 60 here in Ontario, Canada. And our conclusions we decided to organize around the fact that aging well with HIV to us, to the study team and to the research participants, could be thought of as being able to fully realize one's human rights as an older person. And we structured our findings of that study around the UN Principles for Older People, which thematizes 5 overarching categories of rights: independence, participation, care, self-fulfillment, and dignity. And in talking to older people living with HIV, the study team took note that especially those who were diagnosed in the 80s and the 90s faced a triad of barriers to fully realizing those rights. And none of these are actually mitigated by viral suppression. So thinking about these through a social determinants of health framework. So first, traumatic experiences and losses across the life course that have dramatically compromised both social capital and material resources for people who are now older and living long-term with HIV. The second being intersecting forms of stigma. So it was already mentioned by my colleagues on the panel today that there is this intersecting impact of HIV stigma and ageism, and also I would like to add ableism, where the concerns of people who are aging with HIV can be discounted by community organizations, by healthcare providers. And as one long-term survivor in our study put it, they are seen as a person who's living on bonus time. And so their concerns are not necessarily prioritized in the way that they would like. The last sort of element in this triad of barriers to realizing human rights as an older person living with HIV was the mental health impact of uncertainty. And that uncertainty can be at the day-to-day level for people who are having trouble accessing resources for health and well-being, but also it can be about the future, including the security of their health, of housing and resources, and the availability of affordable, safe aging-related care and support. So in thinking about these barriers, I guess some of the assets or strengths that are available to help people age well with HIV are peers and community-based services, which are a very important element of community and of reducing the loneliness and isolation that Giovanni mentioned. Also, I think it's really important to acknowledge the impressive strategies for coping that people have developed in the face of these environmental barriers, and where we do need to make concerted efforts to adapt policy to address some of these barriers, especially when it comes to resource limitations. People have done a remarkable job in setting up their own strategies, both for informal caregiving amongst their community and friends, for managing resource deprivation. And the results of this study that I'm talking about are in a high resource setting. And so it's stark that so many people were struggling to just have their basic needs met, never mind to access the integrated care and support that my fellow panelists have been talking about today. So I think aging well with HIV is about realizing one's full rights as an older person and aging with dignity, with respect, and with access to necessary resources.
Thank you so much, Kate. Let's give Kate a hand here. Thank you for sharing that. Yes, I think all the different cultural specifics really make this a challenging topic. We're going to move to the question and answer portion of this, so if you did have some questions, please, somebody's coming around, we can collect those. In the meantime, I'm going to direct some questions to the panelists. I think we have so much to talk about here. I'm going to start with Angelina, because I know that she, in preparation for this panel, spoke to a number of her peers who are living with HIV. And what is it that you felt really resonated when you spoke with your peers and how they could support healthy aging?
Thank you. So I did speak to a number of my peers, some who are friends and some who are colleagues, a very interesting bunch of women who are all either the same age or going through the same issues. And of course, unsurprisingly, they did come up with some of the issues they face around comorbidities, polypharmacy, frailty, menopause, anxiety, fear, caregiving, all those things. So then I said to them, well, then how do you age positively with HIV? What do you do? And they gave me a whole long list of the things that they do to age well with HIV. I'm not going to go through all of them. But when I looked at the list of things that they gave me, those things fell into 3 categories, and those are the things that feed and nourish their minds, their bodies, and their souls. So they talked about things like, in terms of, I'm going to have a quick read. In terms of things that feed their minds, they make sure that they get enough information and knowledge about what they're going through, what they need to do, how they need to address things. They also talked about how they connect with their peers, because connection as you grow older is really important. They talked about how they use their time effectively, and they also talked, some of them do mindfulness, so that also addresses the need for their minds to being well. They also talked about things that, help their bodies to remain well. One says, I walk my dog. The other one says, I walk myself. I walk in the woods. Another one said that she dances in the kitchen when she's cooking to keep her well. Another one says she loves to eat a lot of chocolate. Another one says she actually loves eating well, so eating good food. So just doing things that actually nourish you. And in terms of the soul, overwhelmingly, most of them talked about how they have a group of good friends. They take on a positive attitude. They drink some wine. They laugh a lot. They talked about loving themselves. Some of them travel, some of them volunteer. And one of them even said, I have a younger boyfriend, and that keeps me really well.
Now, that's wonderful. I'm hearing the same theme of really, we need to engage with people living with HIV to really understand their unique individual needs. And everybody is different. And that's okay. We just need to really honor all those differences amongst our cultures, populations. What works for one culture may not work for another, and that's fine too. But sharing best practices can help us come together on that. I'm going to move to, actually, there was one question from the audience about how to find the journal article. Marlene, if you want to give us a quick heads up on how to do that.
Sure, it's a very easy one, this question. So you go on www.gileadsociety.org, and then you will find a table with supplements, and you will find the content here freely available. And all the other supplements and articles we're publishing. We talked a lot about stigma today, and at the AIDS 2022 conference, we actually launched a supplement focusing on stigma. So also very relevant today when we are looking at aging, ageism, and growing older with HIV. So lots of reading to do for you after this meeting.
Great, thank you so much. All right, we have one question from the audience. Can any of the panel comment on suitable PROs or patient-related outcome measures for routine clinical use? Currently, there seem to be no recommended standard tools, although there are some standard PRO measurements. Are there any that any of the panelists are using regularly or routinely, but either for research or for social justice? Anybody want to comment on that?
Maybe I can share my experience in the metabolic clinic. Actually, we are asking, first of all, people to, let us say, fill PRO electronically before the visit. Okay, and let me say, PROs is not something standard. Again, we spoke about a different aspect of interaction between people needs and environment. And so to me, there's something that should always be there, that is a measure of quality of life. I don't really care which kind of quality of life questionnaire you want to address. The only issue is that, per definition, quality of life is a multidimensional evaluation. And so decide AQ5D5L for Europe, SF36, whatever you like. After that, there may be some questionnaires that really address symptoms and geriatric syndrome. Okay. And then you can focus on different PROs according to what people living with HIV in your area you believe are more interested. I'm more, let us say, a population that is on the 50s. Well, definitely something related on sexual health should be there. I'm more interested in person just after COVID, in which loneliness is present. Well, loneliness, anxiety, and depression should be there. So this is, to me, the way in which we need to address. But mind you, there's something very important. Never collect PROs if you do not return PROs results to the people. Because people get definitely bored of making PROs if they don't realize that they are not commented, they are not used. And so whatever PROs you want to collect, be able to return something that is given back to them. But one single suggestion I give you, and I stop. I put one sentence at the end of any PROs I collect many PROs. What would you like to discuss with the doctor next visit? One single question that goes straight to the fact that PROs must simplify my relationship with the patient, must make me get more easy to listen to the patient, but also must make the patient perspective what is the most important issue to address.
Right, so I'm hearing not just the provider really hearing the patient, but the patient feeling comfortable and supported in asking the questions that they really need to ask. And is anybody else aware of a more standardized patient-related outcome assay that is well documented? I think we need one. We definitely need one as we're moving forward with these concepts. Okay, I'm gonna ask, so we can move along, I'm gonna ask Kate. So we've talked a lot about community and community activism. How do we maintain this energy with community, and how do we support communities, you know, that are just kind of coming of age in different countries where it may be a challenge, there's so much stigma, you don't want to stand out in your community as somebody either with HIV or who supports those kinds of, how do we support those communities to rise up and have a voice and help their governments change?
Thanks so much for that. It's absolutely important for us to start to think about a coordinated effort of older people living with HIV globally. And there is a movement afoot to that end. I won't be the spoiler because it's just coming, but I think that there is a lot of information, and we've seen the first start of that sharing across the globe at the Silver Zone, which was the first ever global networking zone at IAS for aging and older people. And we really saw people coming, talking, sharing experiences across different countries. And, you know, there are some areas where the response to HIV and aging is more advanced than others. And as you say, there are some populations where aging is a newer issue. But those of us who have moved forward in policy change efforts, in efforts to adapt models of care, et cetera, can share those lessons with people in environments where this is just an emerging issue. And I can't wait for that global network to emerge.
Well, we hope to hear more about that when you can talk more about it.
Absolutely.
Thank you, thank you. And I'd also like to speak with Annie and ask, how can we prioritize local, national commitments to addressing the social isolation, the mental health issues? We've talked a lot about how mental health really starts affecting people early on and not just as they get older. How do we help local and national governments to support making commitments for their people who live with HIV?
Thanks, Lisa, for the question. By the way, yesterday was the World Mental Health Day. It was a happy one for many and not very happy one for many others because of the issues on a personal level they face, among them the communities living with HIV, some in conflict zones, in war zones, etc. So when talking about mental health and HIV, and we actually launched a few months ago an integration guide together with WHO on how to integrate mental health and HIV interventions, programs, policies, which are now available also in other 3 languages, so please visit our website. What's important is the realization of One Health approach. And more now, even disease-specific programs are realizing it. It took us a while, but we have come to that realization. And COVID pandemic has also made it possible for many countries because of them seeing visually what it meant, the impact of it, etc. Just briefly, it's a very long theme to talk about, but I think the commitment to that kind of One Health approach, for physical, emotional, and mental together, no matter whether there is a sick health or healthy health, is important. And it is reflected, if realized, in policies at national level, in local policies, or even practices and policies within clinics, within non-health settings. And that's what we are really advocating for. Go beyond health sector. Oftentimes we see policies and guidelines more focused on health sector, while lessons learned from HIV are that going beyond health sector and just really relying on communities, leadership, and engagement. Some of this is possible. I was just making a presentation literally an hour before the session started here for Eastern European and Central Asian women living with HIV on mental health issues. And self-care came up so strongly because of the reliance on individual strength, etc. But as it was mentioned before, some do not have it. So bringing in both psychosocial support, but also mental health intervention and services, including medications that are not always available even within HIV programs. Oftentimes we see people older or younger ending up paying for non-HIV related services. And it is that kind of equality issue. So the commitment is important, and bringing all the partners and speakers and communities, I think, is the answer. Thank you.
Great, thank you so much. That was a great discussion about that, and I feel like normalizing mental health issues is similar to normalizing HIV and just discussing it as just part of your healthcare and your own self-care. So thank you for that. I'm going to end with a question to Giovanni. Giovanni, from a clinician's perspective, what can we do to support people aging with HIV over the long term? I know you spoke a lot about how clinicians can listen to their folks to really assess what's going on. Think about, in terms of bigger picture things, how can the healthcare system and the providers within it help support people aging with HIV?
So again, I would like to go back to what is the intrinsic capacity definition by WHO. Actually, it says that it is defined by my motor capacity, by my cognitive capacity, is defined by my vitality, that is the capacity to produce and spend energy, is related to the sensory capacity, hearing and visual, and is related to the, let us say, interaction, the social interaction. Okay, and so in order to have a healthy aging, I need to be able to support these 5 different dimensions. Okay, how can I do it? Well, definitely, imagine with regard to the motor capacity, it turns to be very important to fight against sarcopenia. Sarcopenia is something that is physiologically affecting the aging process. And so I think that this is an area very new in HIV. We know that the prevalence of sarcopenia is very high. And so imagine nutrition, imagine physical activity. With regard to cognitive capacity, you know how it's important nowadays to address it. Is there something different in HIV and how to engage people? With regard to interpersonal capacity, again, there's all the issue that we already discussed about the issue of stigma and the issue of loneliness. With regard, for instance, of the issue related to the energy balance, is so much important to address metabolic health of people living with HIV. It's not just your lipids, but it is related to your heart, to your bone, to your kidney. To what extent also antiretroviral therapy nowadays are addressing a metabolic health. in people living with HIV, and all the psychosocial that really reflected to the community. But the community is not just HIV community, or rather think that the HIV gets in the context of the chronicity of many other diseases, and try to understand what the environment where I live is offering services for all the people in which HIV, people living with HIV, can benefit of. And so I believe that there's many things to do, both from a medical, from a community, and from, let us say, a social and political context.
Thank you very much. That was wonderful. And I'm going to address this one question last from the audience, because I think it sums up a lot of what we're trying to pull together here. And someone has asked, which comes first, loneliness, HIV, or aging? And I think this just kind of sums up all of the different challenges that we have these days. Now that we have tolerable HIV medications for people living with HIV, first, accessibility, tolerability, and access. And then how do we address all these other things that are coming up for folks now? Mental health is a big challenge for every culture. Getting older, having not enough social support, and how do we have the provider and person with HIV interaction support each other? And then moving past that to policy and governments and systems. And I think we have a lot of great advice that has come to us through this panel. I want to thank the whole panel for being here today. I know it's been a little challenging with the some people being virtual and some people being in person. But I think we've come a long way with all of these challenges in HIV. And now we have the ability to start looking at how to support people as not only that as they get older, but how to have them live their best lives with HIV and have other things also be able to be focused on other than just virologic suppression. So I want to give a big hand to everybody on the panel. Thank you very much. Thank you all for hanging here with us. I know this session went a little bit over the original one, so thank you, and I wish you all a good conference.